Good afternoon, and thank you for the opportunity to be here. We're going to talk about the common complaints that you see an awful lot, but hopefully we're going to discuss some of the times when they're not so common and you have to think, oh, do I need to think more about this in this situation? The objectives are as you see them. They've been printed, and I have no conflicts of interest. These are the common complaints, and you know them all well. Murmur by far and away is the most common reason for referral to a pediatric cardiologist from outside sources. Chest pain is also another common one, palpitations, syncope. And then I put along the bottom, there's a combination of patients we see sometimes that present with either palpitations, chest pain, syncope, pre-syncope, and they'll be sent in with chest pain and they'll have palpitations and they're pre-syncopal. Or they'll have pre-syncope and they'll have chest pain. Or they'll have palpitations and we find out they're having, or chest pain and they're having palpitations, that's what they're experiencing. So there's a combination, and hopefully we'll discuss that and convince you of that as a clinical picture. We'll start off with murmurs, and I like to start off with this. Anytime I talk about murmurs, this is my first line. When I walk into a room, I ask parents and patients about a murmur, if a murmur's been heard, and I say, do you know what a murmur is, or did somebody explain to you what a murmur is, that kind of stuff, and I make it clear to them that a murmur is just a sound. Easily half the parents that come in to see me think that a murmur means something's wrong, and it's actually a physical entity that's wrong. So it's their mindset, no matter what you've said to them, it's their mindset, oh, something's wrong with the heart. And so I start off with murmur as a sound, and you know that. And it's just simply a sound, but when I emphasize that as a sound, instead of something wrong in the heart, you can see the shoulders relax. You can see take a good breath. Oh, it's not necessarily something that's automatically wrong. So I like to make sure that they know it's just a sound that can indicate something wrong, or may or may not be just very normal. They're common referral to us because simply they're common in the population. If you read textbooks and if you read published things and all that sort of stuff, they'll say over 50% of most kids will have a murmur at some time. My personal experience and my belief is that over 100% or 100% of kids will have it. When I was in training, we did those 200 patient a night physical screenings, where you had the stations. I don't know if you ever remember those. At once upon a time, you'd set up screenings, and 10 or 15 healthcare providers would do 10 or 15 different parts of the systems, and we'd run through 200 a night for a couple of nights to help the football teams get through their fall clearances and all that sort of stuff. This was years ago, and that model's not done that much anymore. But I had the heart and lungs for a couple of years as a resident, and pretty much every teenager that I would examine sitting up, they'd be fine, and I'd have them lie down, and 3 or 4 heartbeats, they had a systolic murmur. Easily 70% of them, and it would go away, And so I think my professional opinion, and I tell parents this, is that I think all kids have a murmur at some time in their life. Just depends on who's around to hear it, if someone hears it. So really common, and that's another stress that I do for them. The typical and reassuring history that you all know of really well is the new onset of a murmur after age 2, and you can take that 2 years down as far as you want. 18 months, 12 months, or whatever. If you've seen a child, or if you've known a child has been seen several times in their routine first-year evaluations, and no one's heard a murmur, and they come to me at 2 or 3 or 4 years of age, or they present to you at 2 to 3 or 4 years of age, it's really very reassuring. You can say they don't have a VSD, they don't have serious pulmonary stenosis, they don't have serious aortic stenosis, they're not likely to have tetralogy of Fallot, they're not likely to have any of the complex heart diseases. Those have been screened for in the nursery, the cyanotic complex ones, and you haven't ever heard a murmur. So it's very reassuring that their clinical picture is no problems from a heart standpoint. Even though some of the skinnier kids, their murmur can be really loud. You kind of think, wow. But it can still be very typical for an innocent murmur. When they're not innocent, and these are the murmurs that you would pick up, typically you would say, uh-oh, this is wrong. When a murmur is heard, and I use the term on the table, when you examine the child for the first time, or if anybody listens to the newborn when they're born, you're going to pick up the murmur of pulmonary valve stenosis, aortic stenosis. Sometimes the VSD will be heard right away, but remember, a VSD doesn't have to be heard right away. Equal pressures, right ventricle, left ventricle, they don't have to be going left to right in those first 12 to 24 hours. They will, but they don't have to be heard. And tetralogy of flow will typically be heard right on the table because it has pulmonary stenosis. You may or may not hear the VSD, but most of the time, the tetralogy of flow will have a very prominent murmur. If you hear a murmur at 1 to 2 days of age, there are scenarios when you wait, when pulmonary vascular resistance drops, then you begin to hear a murmur. Mild pulmonary stenosis, you might not hear the first day of life because equal pressures are higher pressures. There's not enough flow pressure differential to make any noise. VSD, again, is not necessarily heard in the first 24 hours of life. Or even before you send a child home, you may hear that murmur at the first day of life, particularly those small muscular VSDs, where it takes a certain amount of pressure difference for it to squirt through and make noise. Atrioventricular septal defects, the canal defects, are pretty common not to have a murmur at birth. It's wide open. Everything's equal. And so they may or may not have a murmur on the first day of life. We'll typically present that. And then any murmur in the first month of life we pay attention to. We don't know. You know, an infant is such a changing entity that when we hear from you guys as a murmur in the first month of life, we pay attention to it, and typically we will echo those folks. You just can't be sure that a murmur was not missed in those first few days of life because of those reasons we were just talking about. This is just a murmur that a picture that shows very typical stenotic aortic valve. You're going to hear that. Flow across that area is going to be heard, and it's going to make noise. So pretty much on the table, same thing with the pulmonary valve, right over the pulmonary area, right over the aortic area. If a child has aortic stenosis and there's sufficient flow, you're going to hear that first hour of life, first minute of life on the table type from that standpoint. Tetralogy of flow. There are two murmurs actually in tetralogy of flow, and it's really cool if you can hear them. They mix together, but sometimes you'll hear that holosystolic murmur of the VSD all the way across. And then sometimes you can move up and you'll hear that of the pulmonary stenosis. But they'll have a murmur, and that's pretty obvious for them. They may or may not be blue. They don't have to be blue. And there's some pink tets, or they may be blue the first time 3 or 4 weeks of age, 3 or 4 months of age. The other murmurs to be concerned about, when you hear the typical murmurs, you say, oh, this sounds like a VSD, that holosystolic murmur. All the way across. And VSD murmurs, other than the small, tiny muscular ventricular septal defects, most of them are harsh. There's a lot of velocities coming through a larger hole. So it's that type sound. It's not the high-pitched of the smaller VSD, and it's not the crescendo decrescendo as in the next scenario. It's not the up and down, the crescendo decrescendo murmur of aortic stenosis, pulmonary stenosis. Both of those murmurs obscure the first heart sound. They occur at onset of systole, so you don't hear the first heart sound. So when I listen to an infant's chest, or even a 4-year-old's chest, and I hear I say, yes. I don't have any of these that are very, very serious. Sometimes you have to tease that out, but when you can hear the first and second heart sounds clearly, even if they have a murmur, that murmur can be other things, but typically they're not any of these that would obscure the first heart sound. When you hear and you're listening very carefully, you never hear that first heart sound, you've got to worry. And that would be quite appropriate that one of these murmurs is one that's obscuring the first heart sound. Also, when a murmur is associated with a click, the early systolic clicks, the variable click with pulmonary stenosis, and the fixed early systolic click of valvar aortic stenosis. So instead of hearing dum 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 dum. It's brip dum brip dum brip dum brip dum brip dum brip 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 brip. That high-pitched second sound, brip 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 dum brip dum brip dum brip dum, is that valve clicking. In aortic stenosis, there's a murmur in there too, so this is a little tough. Shrip dum shrip dum shrip dum shrip dum shrip dum shrip dum. Sometimes you hear the murmur and you can still hear that click in it. Oftentimes the click is easiest heard where the sound propagates. It's down at the apex and up in the aortic area, because it's going to be made, the sound is made best along the line that it's produced. Any diastolic murmur is of concern. Any diastolic cardiac murmur. I was reviewing these slides for the presentation and I realized a venous hum is it can be a diastolic murmur. That I don't think of it as a cardiac murmur, but it's still a murmur or a sound that you hear. And of course, you know, you include the external jugular and it goes away. And I love doing that. But it isn't diastole. And then to be concerned with the continuous murmur after the first week of life, you know, that's the ductus. The typical description of a ductal murmur is that continuous or machinery type flow murmur. I don't usually hear a continuous murmur for a ductus. Most of the murmurs I hear for a ductus are systolic, and it's just a higher pitch. But it gets louder as you move away from the heart, and you also hear it doesn't obscure the first heart sound. So a systolic murmur that gets louder as you go into the axilla is that. Certainly, if you hear the continuous flow, that's likely the ductus. The ductus murmur can also make a series of clicks. I can't make that sound very well, but there's a clicky noise that is published, and people will read about it. I've heard it 2 or 3 times in my career, that if you hear that multiple clicks, that's almost always a ductus. But that's pretty rare. But I have had somebody referred to, many clicks. By the time they got to me, the ductus had closed, but I'm pretty sure they had heard the multiple clicks of the ductus. Special considerations for that. After 2 years, no previous history of a murmur is really, really good, except for older children can have an atrial septal defect that doesn't make any noise early on because they have to get big enough to push enough flow across the pulmonary valve. Remember, the murmur of an ASD is not flow across the septum, atrial septum, it's flow across the pulmonary valve. It's excessive flow across the pulmonary valve, the volume load from the ASD. So what we hear is the soft murmur of valvular pulmonary stenosis from that murmur. But also, if you hear fixed splitting of that second heart sound, dum blip, dum blip, dum blip, dum blip, 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 and it doesn't change when you ask them to hold their breath. It doesn't change with changes in position. It doesn't close like physiologic splitting does. So you hear blip, 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 blip. In a 6-year-old, you say, well, that might be an ASD. Could easily be an ASD. As we mentioned to you about bicuspid aortic valve, a bicuspid aortic valve may not be heard in the first few years of life. Typical for us is teenagers. They get big enough, so a mild bicuspid aortic valve without severe aortic stenosis, that one's going to be picked up early. But a 12-year-old, 14-year-old who presents to you with a systolic ejection murmur, typically a little lower pitched, up in the aortic area, maybe at the apex, typically at the apex, there again along that line, you have to kind of think, ooh, is this a new onset bicuspid valve? Or are we just now picking up this kid with a bicuspid aortic valve? They've gotten big enough to push enough flow across that minimally involved valve that's now making enough noise for us to hear. So I always think about the teenagers. That 2-year-old rule for me, when they get in their teenage years, changes a little bit when I think, hey, I'm listening specifically for the bicuspid aortic valve. And then the classic presentation of hypertrophic cardiomyopathy is sometimes a systolic murmur with obstruction. So children who have obstructive hypertrophic cardiomyopathy almost always have a murmur and almost always have an EKG abnormality. So what can you do with for murmurs? A careful history, review of the previous files. If it's a 2-year-old, 3-year-old that has never had a murmur heard before, you can be very reassuring. A lot of parents, in the stories I get, the referrals I get are parents are concerned, mom's concerned, can you reassure? A lot of times I'll get likely innocent murmur, please reassure or please confirm, that kind of, exactly right. Because that question's been raised and the parents want that reassurance and then they forget about it and the child can live a fairly normal life. Certainly, if you're comfortable with evaluating a small child and they have a murmur, you can wait. You can wait 6 months, you can wait a year. Oftentimes that first year of life, the child's doing great, they're pink, thriving, active, eating well, no respiratory distress, they don't have any serious cardiac disease. You can certainly wait a while to see how that murmur might evolve or may come and go. Characteristic of an innocent or benign murmur is you hear it sometimes, you don't hear it sometimes. You hear it sometimes, you don't hear it sometimes. That's not the case with a pathologic murmur. You can hear that one every time if it's still there. If it's not a small VSD, it's gone away. An EKG is also very reassuring. You have a normal child, normal EKG, no evidence of any volume load on the heart or strain on the heart. Very reassuring that there's not anything serious going on with the child at that time. And then, of course, you can refer, and we get a lot of referrals, and that's not inappropriate at all. We may or may not do echo with a typical story. The innocent or benign murmur, as you know, has that very characteristic. It's called vibratory or musical. I think of it more as a squeaky or honking sound. It's that oop, 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 oop. So you hear the as part of the murmur. That's that vibratory noise. That's the tonal musical quality. And you're pretty much assured with a normal EKG, normal history, that that's probably an innocent or benign murmur. Lay those kids down, it may get significantly louder. That's innocent murmur. It changes with changes in position. I may hear it less loud than someone else heard it, which is very typical. And I tell my parents, if the child gets sick and goes to the emergency room, someone's going to tell you they hear it very loudly. Because with fever and increased cardiac output, they're going to hear that murmur much louder. They come to me 2 weeks later and we don't hear much. Quite a common story. And that's very consistent with an innocent or benign murmur. Those are just some references about the murmurs. Chest pain is another common presenter to us, and it's really nice when they walk in my office. It's 95 to 99% of in children and adolescents who have non-traumatic chest pain, it's not of cardiac origin. That's really good to know, and that's our explanation that we have to reassure a lot of folks that the chest pain is not likely of cardiac origin. They're kids, the coronary arteries are normal. So it's not usually the coronary, mostly the chest wall. Can be some respiratory symptoms as well. People will have chest pain with their respiratory symptoms, but mostly the chest pain in children is chest wall pain of different types. There are some of serious concern. These are not so much cardiac, but if someone comes in with chest pain, especially with acute onset of chest pain that a parent's worried about, you've kind of got to go through the is this an emergency type thing, cardiac or not cardiac. But these are non-cardiac, and certainly you just kind of got to put yourself in, do I see an ill child? Do I see a child who has a serious episode of chest pain? All those are quite characteristic and fortunately are pretty rare, but not unheard of. Spontaneous pneumothorax in a teenager, big teenagers, big healthy 15, 16-year-olds is not unheard of. They'll present with chest pain and trouble taking that breath. Cardiac causes of chest pain that are quite serious and concerning include the cardiac ischemia or infarction. The tachycardias will often present with, I feel it in my chest, even though it may not be true pain. Heart failure can cause some chest pain and discomfort. Aortic root dissection, fortunately quite very rare, but it's a very characteristic chest pain. And then pericarditis will often cause a pretty significant chest pain. When do you worry? Fortunately, very rare, but suspected aortic dissection. That's that tall, skinny kid. Whether you know they have the diagnosis of Marfan's or Loeys-Dietz or Ehlers-Danlos, If you know that, then you're really concerned if they present with tearing, searing, posterior chest pain. That's certainly problematic. Fortunately, that's extraordinarily rare. As is pericarditis, but pericarditis is quite real. Acute pain that's worsened when lying supine. The pericardium falls against the heart and is irritated, and they lean forward to relieve it as the pericardium falls away from the heart. It's a clinical diagnosis. It is not an echo diagnosis. Echo is often used in the setting of pericarditis to make sure there's not an effusion, but it's a clinical diagnosis. An EKG in that setting can be quite helpful because it'll show the acute signs of pericarditis from that. Exertional chest pain, well, we could spend the whole hour on this. This is a tough one. Certainly that's a when to worry, and how to make the right decision. Exertional chest pain will typically warrant an echo. We echo a lot of kids with exertional chest pain that are normal, as we should. We should be getting a lot more normals than we should be getting positives, because our concern should be high enough. And certainly the concern is for cardiac insult, ischemia, or infarction. The causes for that ischemia or infarction outside of trauma was anomalous origin and or course of the coronary arteries. Hypertrophic cardiomyopathy it can be a chest pain, especially with arrhythmias. And then the rare but real coronary artery diseases, our kids with Kawasaki's. And I put question mark COVID. We haven't seen a lot of coronary involvement with COVID, but boy, it's following along the same lines. We haven't seen the late aneurysmal formation and those kind of things. And as you know, with the Kawasaki's, if they've had clear echoes, their first several evaluations, they're not likely to have it. So if you have a child with a history of Kawasaki's who was cleared by echo several times, they're not likely to have acute coronary involvement. But certainly those kids who did have coronary involvement presenting with chest pain later in life, that's very much of a concern for us. Hypertrophic cardiomyopathy can cause ischemia and or infarction two ways. In obstructive hypertrophic cardiomyopathy, it's hard to get blood to the coronary arteries themselves if you're obstructing left ventricular outflow tract. And also, it's just thick muscle, and it's harder for the coronary bed to provide that thick muscle, particularly at times of exertion and effort, when you're squeezing down and increasing demand. So you increase demand and you prevent flow, and they can get the chest pain and or serious arrhythmias. That's how they go down with hypertrophic cardiomyopathy. And you likely are aware that hypertrophic cardiomyopathy is the most common type of sudden unexpected death in the adolescent and the young adults, unexplained and unexpected until afterwards. Previously healthy until it happens. Anomalous origin of the right coronary is another one. It's made the news a few times over the years, and athletes and all that have gone down. It's when the proximal right coronary comes off in the wrong place, comes off over on the left, and it runs between the great vessels. Turns out small kids don't have much problems with this. They don't have a big enough aorta, a big enough pulmonary artery, and it doesn't expand enough. This is a nice diagram of it. You can see the right coronary artery coming off here and running between the great vessels. It takes a certain amount of effort, takes a certain amount of size to get those vessels big enough to where they enlarge with effort and increased cardiac output to squeeze that artery. So this is a common story of they go down at 12, or they go down at 14 or 16 or 18. And a couple of the professional basketball players have had this over the years, and they've had a basketball career, and then have gone down with an anomalous origin of the right coronary artery. I'm sorry. Another one that causes ischemia and infarction is anomalous origin of the left coronary artery from the pulmonary artery. You may have heard the term Al-Kappa. It produces infarction. It's actually infarction by perfusing myocardial tissue with deoxygenated blood. And it'll also, since it's in the pulmonary, coming off the pulmonary artery, and pulmonary artery pressures are lower, it'll run off in diastole into the pulmonary bed instead of into the coronary bed. And that's just a nice diagram or drawing of the anomalous origin of that left coronary artery. This will often be seen early in life. These kids will sometimes present with just severe irritation. Infants who have this are actually infarcting their heart, and they'll be just irritable as can be. And you work them up, there's no reflux, there's no other things, they're not doing the Sandovers or anything like that, they're just irritable as can be, and it's because they don't know how to tell you they're infarcting, that they're feeling the acute ischemic pain of infarction. And so it takes kind of a high index of suspicion if you get a story that you just can't explain anything about, and they're just as irritable as can be. Certainly the muscle can be damaged, and these kids can present with heart failure and or a weakening heart muscle from that standpoint. But oftentimes there's a clinical scenario before that. This is an example of a child who presented at 4 months of age. Very typical EKG diagnosis is those deep Q waves and 1 in AVL, and very deep, broad Q waves in V5 and V6. That's the left side of the heart. That shows you very well. And I need to point out to you, these are half standard. So those Q waves are twice that size. They're big, half standard. Those are impressive. Wow, look at those Q waves in 1 AVL and over there in V5 and V6, and you can double those in your mind, and that's significant. There's a lot of loss of tissue with those Q waves in the left chest in this child who presented. And this child presented in failure, heart failure, because the left ventricle had been so insulted. So what are the options for this case? Getting a history, good history, careful history, do it again, get a really good detail of what's going on. It's really tough, but the history helps a whole lot. Certainly an EKG is quite helpful. An EKG should pick up a hypertrophic heart. Lab studies, inflammatory markers, troponins. A lot of times in my receiving information about about a patient with chest pain from an emergency room, I say, oh, they did troponins. What's the chance of a 12-year-old needing troponins when they go to the emergency room with chest pain? I don't mind it at all, because it's when the story comes to you and you're worried about it and you wish they'd gotten troponins or so I don't worry about the troponins at all. They're almost always going to be negative in a child, and the typical story is not coronary artery disease with insult, but when it is, it is. And when you want to worry about it, so troponins I don't mind seeing at all. Particularly if it's suspected. And in certain times you can do ambulatory EKG monitoring to see what's going on at times of the chest pain, depending on the clinical scenario. And other options are typically from our standpoint would be echo stress testing with EKG monitoring, and but usually we take care of that when they're referred to us. Those are just some referrals for chest pain. Move on to palpitations, another very common presentation. And this is one of my favorite patients. This is a 4 or 5-year-old who complained that she felt her heart beeping. And I always put that into perspective because that's exactly what she was feeling. And this was a 4 or 5-year-old, and for a 4 or 5-year-old to complain of palpitations, usually something's wrong. So if you're seeing a 5 or 6-year-old, they don't make this up. They don't know how to make this up. A 12-year-old might make it up, or a 12-year-old might experience something and rationalize it as to what's going on here. But a 4 or 5-year-old won't, and this is one of my favorites. This was SVT, and she knew her heart was beeping. That's what she was telling. Sometimes we'll get, it'll be an abdominal complaint. Sometimes I've had a couple patients whose primary complaint of SVT, rapid beating of their heart, because they were feeling it in their belly. And so they came to your office or came to whatever office, and they presented with some abdominal discomfort. And when you asked and found out, it was actually they were feeling things going. But palpitation, literally the word means I can feel my heart beating, whether it's in a normal rhythm or abnormal rhythm. So palpitations are pretty common. A lot of different causes. Certainly if there's an arrhythmia, most people don't feel single early beats. A lot of us have PVCs, a lot of us have PACs that we never know we had until someone listens or finds out about it. Some people are bothered by them. Most people feel that the post-extrasystolic pause, I'm going to explain that little phrase. An early beat doesn't fill up very well. So an early beat, we usually don't feel the early beat. But an early beat causes a pause. And so it resets the heart, and the next beat is a really big, overfilled beat, and it goes, boom. And that's what they usually describe. That's what most people feel. It's that kick, oh. that they had something early. They rarely feel the early beat. So if you get them that, and I call it a thump. Did you feel a thump? And they say, oh yeah, yeah. And that typically means they're feeling that first beat after the pause. There are different types of certainly arrhythmias that cause them. The rare accelerated rhythms, occasionally we'll get an idioventricular rhythm or we'll get an accelerated junctional rhythm, really, really rare. And those are at slower rates than the real serious faster heart rates. So somebody's feeling their heart running along at 130, 140 beats a minute, persisting when it shouldn't be. Sometimes we'll think about, is it an accelerated rhythm, an accelerated idioventricular rhythm, or an accelerated junctional rhythm? Again, really, really rare, worth evaluating if that's the clinical scenario from our standpoint, but not too much of a problem for the child. And then heart block. Various degrees of heart block can be palpitations. Again, you feel those long pauses. If you skip a beat or you don't conduct a couple of beats, the next beats are pretty big. So EKGs are really nice to see if they're PACs, PVCs. There are some medical conditions that cause it. Anemia, hyperthyroidism will have people feel their heart. Boom, 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 boom. Typically it'll be in a regular rhythm, but they'll still feel it and they won't like it. Dehydration, same thing. Get very dehydrated. Your heart rate's going to make that appropriate response, 110, 115. Boom, 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 boom. And they'll feel that. Anxiety will also cause palpitations with increased heart rate, but it also tightens up the chest wall. So when we get anxious, our chest wall tends to tighten up. We feel our heartbeat pounding hard. So anxiety is a pretty common presenter for us, or pretty common cause. And then I'd like to always ask about toxins, drugs, caffeine particularly, as causing regular beats. In the young adult, late teens and young adult, you could slide that down the scale a little bit nowadays. It seems like teenagers are drinking a lot more coffee than they once were. The 12-year-old, 13-year-old going to Starbucks is not an uncommon scenario now. It used to be you had to be adult age to drink coffee. I'm dating myself, but that was just the clinical, was a 16-year-old wasn't drinking a lot of coffee. But caffeine is by far the most common cause of PVCs in the late teen, young adult population. So we always ask about caffeine, and these days Red Bull and the highly caffeinated drinks are not an uncommon cause. When do you worry about palpitations? When the rhythm is irregular and it's not, thank you. When the rhythm is irregular and it's not physiologic, respiratory, or sinus arrhythmia. Certainly an EKG is quite helpful. You assess for atrial or ventricular ectopy. PACs are almost always benign. PVCs are usually benign if the heart is normal. You need to know there's not a cardiac tumor. You need to know there's not myocarditis. You need to know some other findings. You need to know there's not a hypertrophic heart. We need to know there's not arrhythmogenic right ventricular dysplasia, those kind of things. So a lot of kids will have PVCs, and they can be benign and normal, but we typically evaluate those kids, make sure that they have a structurally normal heart, and then we can reassure them that their PVCs are not problematic. Most of those PVCs are a timing event. There's a certain amount of time that the ventricular myocardium will fire, after which it will fire. It's just a site that decides to fire on its own. If you bring the heart rate in faster than that, it goes away. So these kids get active, and their PVCs are completely suppressed because they're just not allowing enough time. That's very reassuring and pretty common. And then as we mentioned before, if there's AV conduction impairment, second-degree heart block would be an irregular rhythm. Third-degree heart block is going to be a slow but regular rhythm. Boom. Dum, 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 dum. I think about heart block, other than the teenage athlete that's really, really in good shape. But it's really nice to have an EKG from that. PVCs in the abnormal heart, cardiomyopathies, both hypertrophic and dilated, put the myocardium under stress. Myocarditis, an irritable myocardium. Certainly myocardial injury or trauma. One of my favorite patients I followed for years was a young woman who got kicked by a horse. She was a cowgirl. She was a rancher, daughter, and she got kicked by a horse early in her life, and she had a little nickel-sized area of injury on her heart. Fortunately, she recovered, but she had PVCs, forever from that site of injury. The unusual ones: arrhythmogenic right ventricular dysplasia, catecholaminergic, polymorphic ventricular tachycardia. Those are kind of in our realm. But you kind of have to think, is this a serious or a potentially life-threatening arrhythmia? The channelopathies, some of them will cause just sudden unexpected death or sudden unexpected syncope. But some of them will have some PVCs as hallmarks of those, or as harbingers of those abnormalities. Certainly you'd worry about this. Wide complex rapid tachycardia. So if the complaints are a rapid, excessively fast heart rate, then yeah, you worry about it. Whether it's ventricular tachycardia, like this, or whether it's narrow complex tachycardia, like the picture on this side, you're still going to worry about it. Fortunately, this tachycardia is not very often life-threatening. It's problematic, and most people don't like it. It's not very often life-threatening. And then, as you know, a common cause of this is this pattern, short PR, delta wave on the EKG, and that's WPW. And that's not an uncommon thing, as you know, in the population. So if the palpitations are associated with excessively fast heart rates, and I like to make noises, so I will typically ask the kids, is your heart going boom, 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 like that? Or is it going boom, 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 a little bit faster? Or is it going brrrr? And if it's going brrrr, too fast to count, mom puts her hand on the chest and she can't count it, or a nurse has tried to count it and it's too fast to count, then it's usually SVT. Or VT, but most commonly SVT. But sometimes mom will come in and she'll say, when I put my hand on it, it's going like this. Well, that's 110, 120 or so. That's not so fast. And so then you have to work through, you don't worry about it being an excessively fast heart rate. When do you worry? Another time to worry is if the palpitations occur just before a collapse. So if someone presents with a syncopal event, a sudden collapse event, and they say, I felt my heart beating or racing away right beforehand, then they're likely in a ventricular arrhythmia. This is an example of long QT syndrome. See the T waves? The T waves go from here, this one goes from here all the way out to there. So this individual had QT prolongation. They had a syncopal event. They had tachycardia just before their syncopal event. As you know, not all those events end up dying, so they survive, and the time to intervene. But it's nice to pick that up. They will say, hey, yes, I felt my heart racing away, and then down they went. Again, what can you do for palpitations? Careful history. I always check for excessively fast heart rates. I try my best to rule that out from a history standpoint. Can't always do that. That's not always possible. So we put on monitors for that sometimes. It's not always clear how fast they're going. A lot of times parents won't know how fast they're going, but they went fast, or they'll say it was really fast, and I'm not sure how fast really fast was. So we put a monitor on. Love to get an EKG in this setting to make sure they don't have WPW, to make sure they don't have hypertrophy, QT prolongation, or ectopy, ventricular atrial ectopy. Ambulatory monitoring is typically used in this setting. Oftentimes, I'll use it with provocation, and I put that down with intentional provocation. If a child tells me that every time I do this, I feel my heart race away, then I'm going to try to put on a monitor and have them do this. Or if they say every time I drink 5 Red Bulls, this is what I feel like, I'm going to tell them to go home, drink 5 with the monitor on, and drink 5 Red Bulls, and let us see what's going on. So you try your best to see it, and that's the whole purpose. So I say with intentional provocation, we want to see an episode if we have them wearing a monitor, and then cardiology referral also from that standpoint. We'll finish up with syncope. Thank you. Syncope is, in other words, is a simple faint. For years and years and years, vasovagal event or vasovagal syncope, really, really common term. And I just love this depiction. I've used this several times. Is that these folks may not have understood the really complex reflex abnormality that is neurocardiogenic syncope, which is vasovagal or fainting, but they certainly understood it really, really well. Because do many of you guys know what this is? A fainting couch. I love it. I love it. Somebody came up with a couch just so they could put it somewhere so that a woman could come along and faint appropriately. And if you notice, this is another step. Oh, I'm sorry. they depicted this picture very nicely. What do you do if you want to faint or need to faint at the right appropriate time? You tighten up your waist. I love this depiction. So you constrict venous return from below. You restrict it just enough that you can stay alert until you decide to hold your breath just a little, and down you go. So you didn't have to hold your breath really, really hard. And I'm being serious. This is how they worked it. You didn't have to hold your breath really, really hard if you were already limiting pulmonary systemic venous return. You just had to kind of, oh, rat, and down we go. So they understood it really, really well, and they also knew that everyone was going to wake up. Right? A fainting event, a neurocardiogenic syncopal event, is a benign event, even though it may be dramatic, and it can be traumatic, unfortunately. So we do pay attention to them. But I really love the understanding of that. And syncope, most syncope is neurocardiogenic syncope. You know it as vasovagal. There are other words. Neurally mediated syncope is the same thing. But it's a transient loss of consciousness followed by spontaneous recovery. And it's a reflex abnormality. It's a reflex inappropriate slowing of the heart rate or inappropriate response of a heart rate to low blood pressure. It has a very classic, typical clinical picture. I'm going to go through this pretty quickly just to emphasize that it's very much a reflex that's been kind of figured out. I don't use the term vasovagal that much anymore because vessels, vagal nerve, it's not just the vagus and not just the blood vessels. The triggers a sympathetic surge, and there's a whole lot more involved. But it is a vasovagal. It is a simple faint. But when I explain a little more to parents and describe some of the symptoms and how they're caused, they say, wow, yeah. And oftentimes the parent will say, yeah, I did that when I was a teenager too, when you just walk through the symptoms of it. And I'm not going to spend much time on this. I'm just using these slides to show this is a pretty significant involved reflex. And there are a lot of places along this reflex that you can treat it. And there are a lot of things you can do to prevent the worsening of it. And there are several different therapies along the way. And the reason I do that, well, I'm going to finish out, I'm sorry. This is a very typical clinic presentation of neurocardiogenic pre-syncope or syncope. Lightheadedness, weakness. It's that rush, the lightheadedness. I avoid using dizziness in my presentations. A lot of folks will say I'm gotten dizzy, and first thing I do when they come in my office is I say, let's talk about dizziness. Is it the room spinning around you? Vertigo, which is really unusual. Or is it lightheadedness where you're getting woozy? Is it that, whoa. Now the room may move, but it's not the room spinning. That's rare. But the wooziness, whoa. It's pretty common, and I call that lightheadedness, and we'll usually distinguish that. And then I ask them if they get weak, but it's not so much weak that I can't run a mile, it's weak that my knees are going. I'm getting wobbly here, and I'm holding on type thing. It's because the big muscles aren't getting enough blood flow. Nausea is really common. You're depriving flow to the gut, and so they get that sick, wished I could throw up type, but they don't. They rarely ever throw up unless it's just after a meal. So you ask them that, they want to throw up, they think they might feel better if they threw up. And sometimes that's one of the more prominent features. I just get abdominal pain all the time. Typically the heart will pound fast, so they'll have palpitations. If they drop your blood pressure, your heart rate's going to appropriately respond to increase heart rate and increase contractility. Boom, 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 boom. 110, 120 beats a minute. Doesn't feel very good. You don't like it. You're not doing anything. You're standing there, but your heart rate's 120, and you can feel it pounding through your chest, so it's really bothersome. Visual field changes are really, really common. The furthest away a drop of blood has to go is all the way up and all the way back. What's all the way back? Our occipital fields. Yeah, our visual fields. And so one of the earliest signs of pending syncope is the visual field changes. And the kids will typically describe how things will come in. Most common is black shields from the side. Second most common is the spots. I can see the spots. Some kids will fade to gray. Not many kids this day and age know about the gray screen on a TV. I ask about that sometimes, but not too many of them know about the gray screen. But that's still what they see sometimes. Rarely will they see a bright light or something like that. But it's the visual field changes. Kids will oftentimes say, I blacked out, but did not lose consciousness. So they lost their visual field, but they didn't lose consciousness, so they could still hear. Now, sometimes that precludes actual loss of consciousness, and that's the next step. But some kids will say, hey, I blacked out, but I didn't pass out because I sat down or I got down or somebody came and helped me. So if you hear that, it's pretty common. And pallor is just almost always there. And I never ask the patient if they got pale. I will ask people around them, moms or whoever, what they look like. And they will almost always say they were pale, or they were white, or they looked bad. And I've been surprised over the years. Sometimes I'll ask folks who had episodes at school, mom didn't see it, or no one with them has seen the episode, but they had episodes at school, and I'll say, well, what did your classmates say? Or did anybody see this happen? What did they say? And almost invariably, somebody will have said, you looked really bad. You know, it's just not common for us to look at somebody and see if they're pale and weak and sweaty to think. So almost always somebody will say, yeah, they told me I looked really bad, or I looked pale, or something like that. Or the teacher tells mom that the child looked really pale. So pallor is really, really common. SVT doesn't usually cause pallor. It usually causes you to flush. It will cause you to get pale if you go to the very end, but not typical. Seizures, we usually flush with seizures. We usually get red and all sorts of stuff. So that marked pallor, and the first sign of it is right here in the lips. We used to tilt a lot of these kids, standing right beside them. I mean, in the thousands over the years when we were studying it. And we stand right beside them. The first thing that goes is they'll lose color in their lips. They'll say, I don't feel good, and their lips will go gray, and then they'll go white and go. And then another common scenario of this is sometimes they'll feel chest pain. When the blood pressure drops and you still got to use your chest wall muscles, you've got to keep them going, they'll tighten up a little bit. So here's somebody who has palpitations. Sorry, wrong button. In that situation, they'll have palpitations, they may have chest pain, and they'll have presyncopal symptoms. So we'll see that as a common complaint, and they might present with any of those, and we'll figure out all of them that are part of it. The reason I went through that explanation of typical syncope, and by far the most common cause of syncope, is that you need to worry when it's not that. Any other syncopal event that's not quite typical of neurocardiogenic type presyncope or syncope, you got to worry about. You have to go it. You know, is it seizures or is it anything else? But when the history is not consistent with lightheadedness, weakness, nausea, pale, eye changes, certainly, as we mentioned, if a syncope occurs in the setting of excessively fast heart rates, that is a problem. Even SVT is not usually a syncopal event until, but it rarely is. And so if somebody has SVT and goes down, we send them to have it cured. The next step of that is a radiofrequency ablation or a cryoablation of their SVT. We don't let it happen again. We try our best not to let it happen again. And also, when syncope occurs in the unusual situations, this is a long QT. Every once in a while, somebody will get startled. One of the long QT types is response in long QT2 is a sudden startle, and out they go. I learned it as the alarm clock syndrome. Long QT, before we knew the types in my training, one of the definitions of it was alarm clock syndrome. You suddenly get startled, and down you go. Unfortunately, we picked up an 18, 19-year-old young man who was collapsing with long QT, and his story was that his dad and brothers used to invite friends over and watch them scare their brother. As he came down the hall, they would jump out and scare him, and he would pass out and collapse. Of course, they felt horrible about it, but they startled him, and down he went. Fortunately, he survived those early ones, and we figured him out years later. But and the other is the unusual near drowning or the unusual drowning, almost drowning. Long QT drowning. The number one cause of death in long QT syndrome is having an episode when you're in the water. So drowning, because if you have an episode of torsade and you pass out and you come back and you're on dry land, you're alive. If you have an episode of torsade and you're in the water, you don't come back, you drown. So an unusual drowning, a drowning in a typically good swimmer, you have to think of long QT syndrome. Worry about it when it's associated with conduction impairment. That's an EKG or Holter monitor. When syncope is associated with exercise, exertion, I call it mid-stride exertion, mid-stride collapse, very, very concerning. It's very tough to decide. Neurocardiogenic syncope, just after vigorous exercise, is pretty common. You vasodilate. If you're relatively empty, as long as you're moving, you're pumping blood back to the heart. As soon as you stop, if you're relatively dry, you stop sending blood back to the heart. Thank you. And down you go. So it's coming off the field. It's in the huddle, basketball, volleyball. Sometimes you're running up and down the court and you suddenly stop. Common for me is, I call it the water fountain syncope, is kids will do their drills at the end of practice. You know, the coach will make them do the line drills and all sorts, suicide drills, whatever you do, and you go 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 really, really hard. You push and push and push, and then you suddenly stop. Right? Practice is over, whistle blown, and they go walking over to the water fountain, and down they go. It's neurocardiogenic syncope. It's not the same as running down the basketball court and down you go, or running down the football field and down you go. Cross-country runners is a little tough. Most of those kids at the end of the race will be maximally vasodilated, relatively dry, and they'll go down, and that's usually neurocardiogenic. That's rarely arrhythmia. I think we're about out of time. I think we're about done. Those are pretty kind of obvious things. If there's syncope with exertion that you're concerned about, we see them. We should see them. They at least warrant, they definitely warrant an EKG. And an echo is, we echo a lot of folks with syncope with exertion from that standpoint, looking for these kind of things, and certainly a history. This is just a couple of examples, polymorphic VT and torsade over there on the left. I'm sorry, that's your right. What can you do? History. Certainly EKG up front is really good. The systems we use nowadays, I rarely need to repeat an EKG if the outside physicians have done an EKG and I can see it and read it. And with the electronic systems now, it's pretty clean. Fax was once upon a time horrible. And then we'll just end. For a summary, the common complaints are really common and are rarely associated or not commonly associated with really serious things, but some are. And so your awareness of when to be worried, when to call us or ask us to see somebody is certainly appropriate. Certainly you can initiate some of the initial screening. If you have access to an EKG, it's really reassuring. And in Yakima, I'm around and all. I've been a consultant all my life. I was an EP doctor for years and years and years. And I don't mind anybody calling me at any time asking me to look at an EKG. And I will get to it as soon as I can because it's so important. And I try to teach folks, hey, get an EKG, and if that looks good, the story is not so serious, we'll see them. But we don't have to see them right then. Or you can reassure the family. So the EKG will sometimes be quite helpful. And then a good history, as I think I've tried to emphasize throughout the whole thing, a good history is really, really important. It takes a little time. I have that time as a consultant because that's what they're sent to me for. Sometimes in the busy part of a day, it's not so easy to spend all that time. And so it just depends on what you can.